schwannoma. A 45-year-old male presented in our OPD with the chief complaint of double vision, foreign body sensation in left eye since 1 month. On a detailed examination, there was also deviation of angle of mouth towards left. He had appeared to our OPD after surgery for left CP angle tumor, which was performed 1 month back. On ocular examination, the vision was 6/6 in both eyes. Left eye was 15-degree isotropic by Hirschsprung test. There was slight limitation in abduction in left eye. Rest of the ocular motility examination was normal. There was diminished corneal sensation in left eye. The fellow eye being normal. Slit lamp examination, cornea was lustrelation in left eye, and tear film breakup time was less than 7 seconds in left eye. Rest of the examination, including the pupil, field, and fundus, was normal in both eyes. On asking the patient to close the eyes and gently trying to pry the eye open, there was mild weakness of orbicularis muscle on left side, but no lag ophthalmos was seen. Schirmer's test 22 mm in right eye and 8 mm in left eye after 5 minutes. So, a clinical diagnosis was made of a case of dry eye with 6th and 7th nerve palsy in left eye, following trigeminal schwannoma after surgery. The secretomotor parasympathetic fibers for the lacrimal gland travel in the 7th nerve and leave the nerve at geniculate ganglion as secretor petrosal nerve, then synapse in pterygopalatine ganglion and through the zygomaticotemporal nerve innervate the lacrimal gland. As we correlate anatomy with radiology, the tumor is located close to the intercranial part of 7th nerve and likely to get damaged during the removal of the tumor. Prior to surgery, decreased sensation on left side of the face was the sole presenting complaint of the patient. During surgical removal of the tumor, the proximity of 6th and 7th nerve to the 5th nerve explains the post-operative involvement of these nerves. The dry eye in this patient is due to injury to the nervus intermedius, which contains parasympathetic fibers to the salivary gland and lacrimal gland. This explains the dry eye in 7th nerve palsy with no leg ophthalmos. Clinical implication: injury to 7th nerve before entering the internal acoustic meatus causes dry eye as seen in cerebellopontine angle tumor, while injury to 7th nerve after the geniculate ganglion does not. Hence, the presence of dry eye differentiates the anatomical location of 7th nerve lesion. Yes.
What about your V2 and V3?
So V2 and V3 went before the surgery. They were not. The sensation was reduced, but he came to us after the surgery. So then V2 and V3.
You have not checked anything before surgery. Patient came to you?
After surgery, the patient presented to us after the surgery. Before the surgery.
The corneal sensation was not in this patient.
No, ma'am. After the surgery, it was not when he came to us.
So V2 was
Diminished.
V1 was diminished.
Yes, ma'am.
And V2 was intact.
Yes, ma'am.
So what was the plan of action for this?
Ma'am, the patient was kept on follow-up with the lubricant agents were given. After 6 months, slight improvement was seen, then the patient was lost to follow.
You are not taking anything you know can be done. Something new, something that has been tried in recent past. Neurotopic keratitis. Such like trigeminal schwannoma has been operated and there is a element of neurotopic keratitis. You know something surgery can be done for this. Anything you know? But you are saying this is a one-off case for you.
Yes,
So
sir.
you are getting it over here.
Yes, sir.
Something new should be there or something should be something important in this. Apart from that, now you should know much. Is there any surgery like this? Neurogenesis or neuron.
You need to change your diagnosis not just to 6th and 7th, to 5th as well.
meningioma, case report by Dr. Rema Singh.
Good afternoon everyone, myself Dr. Rima. My case today is asymmetrical papilledema due to meningothelial meningioma, a case report. Papilledema is a term that is exclusively used when a disc swelling is secondary to the increased intracranial pressure. Papilledema is usually seen bilaterally but can be seen asymmetrical and rarely unilateral. The optic nerve, which is comprised of retinal ganglion cell, axons and glial cells, is sheathed in all three meningeal layers and is continuous with the subarachnoid space of the brain. Intracranial CSF is by this way contiguous with the CSF surrounding the optic nerve, allowing the elevated intracranial pressure to be transmitted directly to the optic nerve. The most common cause of papilledema is intracranial hypertension, reported in 67% of cases. Previous studies have reported that approximately 16% of the cases of papilledema are secondary to intracranial masses, 7% due to intracranial hemorrhages, and 7% due to venous sinus thrombosis. Asymmetrical papilledema is defined as greater than or equal to 2 modified Frisson grade difference between the two eyes. A 65-year-old female was brought in her OPD with the complaints of diminution of vision in both eyes. In right eye, the vision was finger count close to face, and left eye, the vision was finger count 1 meter, which was gradual in onset and progressive in nature since 1 year. She also presented with episodes of headache, moderate to severe in intensity, since 6 months, which got worsened in the morning or while lying down. Patient had no history of redness, glare, discharge, ocular pain, colored halos or photophobia. She had no history of diabetes, hypertension, breathlessness, ocular trauma, ocular surgery, head trauma, smoking, alcohol consumption, any drug or medication consumption. She had no significant family history. She had no significant past history of any surgery. The general examination of the patient was conscious, non-cooperative and was disoriented to time and place. The blood pressure was normal, the pulse rate was normal, the BMI of the patient was slightly overweight, which was 27.5 kg per meter square. The systemic examination in which the central nervous system, the patient was alert, conscious, but was not well oriented to time, place and person. She was not able to speak. There was no sensory deprivation. The touch, pain, proprioceptive temperature was present. The anterior segment examination in right eye, the pupil was mid-dilated and there was sluggish reaction with grade 3 pupillary reflex, and in left eye the reaction of the pupillary grade was grade 1. The IOP was normal, which was measured at 1:30 p.m. On posterior segment examination right eye, the media was clear, the disc shape was spherical and the disc margins are obscured and elevated in all the 4 quadrants. The vessels are dilated and tortuous. There is obscuration of the inferior nasal vessel leaving the disc. There is multiple drusen which is present at the macula. The OCT of the disc shows increased retinal nerve fiber layer thickness in all the 4 quadrants. The disc height is 1410 micrometer. This is suggestive of grade 3 papilledema in right eye. In left eye, the media was clear. The disc shape is oval. The height of the disc is 1.72 mm and the width is 1.67 mm. There is blurring of the nasal and the superior margin of the disc. The CDR ratio is 0.3. There is a C-shaped halo with feathered border is present. A temporal gap that obscures the underlying retinal details is present. There is a obstruction of the thickening of the normal retinal nerve fiber layer anatomy. This is suggestive of grade 1 papilledema. The investigations were done where the complete blood count, there was a high leukocyte count. Rest all the investigations was normal. The visual field testing and the color vision could not be done. This is the MRI, contrast enhanced MRI of the patient, where there is a well-defined homogeneous enhanced lobulated mass and the size is 5.5 into 5.2 into 4.5 centimeter noted overlying the left side of the planum sphenoidal and the floor of the middle cranial fossa. There is extensive perilesional edema causing a right-sided subcalcine herniation. Lesion is anteriorly obscuring the left orbital apex, partially encasing the left optic nerve and the optic chiasma. The lesion is encasing the left cranial nerve 3 and abducting the left cranial nerve 4 and 5. The intraorbital course of the optic nerve appears tortuous with early changes of papilledema in left eye and established papilledema in the right eye. The patient was referred to a higher center due to the limitations of a current institution where surgical risks were assessed based on the patient's general condition, the tumor location, the age, the tumor size. Unresectability was due to the following relation of the tumor: encasement of the left supracranial ICA, MCA, PCM abducting the basilar artery, encasement of the left cranial nerve 3 and the abducting the left cranial nerve 4 and 5, and encasement of the pituitary stalk. Patient was started on chemotherapy followed by radiation therapy with every 6-month follow-up. Discussion. Papilledema is usually bilateral but can be asymmetric or even unilateral in 10% of the cases. Asymmetrical papilledema can be a sign of conditions that causes elevated intracranial pressure such as brain tumors, cerebrospinal inflammation or idiopathic intracranial hypertension. Visual loss from papilledema usually starts with an enlarged blind spot and progress to arcuate nerve fiber-led defect. Central visual acuity is initially normal in papilledema. Very asymmetric papilledema may result from differences in the sizes of the bony optic canals, supporting the concept of compartmentation of the perioptic subarachnoid space. Because papilledema is often associated with CNS tumor, the prognosis is guarded to poor. Orbital tumors may occasionally be surgically removed during exploratory orbitotomy, perform exenteration of the eye, and orbital contents when the mass is localized near the globe. Thank you.
What was the reason of your papilledema in your case?
Sir, the diagnosis was meningioma and the type was meningothelial.
No, that is okay, but what was the there can be meningioma because the whole made a meningioma they would not cause. What was the reason? Obvious on your imaging. Can you tell me the reason? That was obvious on your imaging. And that was not contrast. You were telling contrast, that was a treat. That was not a contrast image. The last one,
Yes,
the corner section you should.
Can you go back to
Can
the
you go back
slide?
to the slide? The corner section, last one. Wow, yeah. Can you tell me the reason for the papilledema in your case?
sir, actually there's two
I
reasons.
see this. Don't go to the whatever the obvious theory is over here. Can you tell me one?
So, there
I
is
see your this right.
there is herniation of the subpharyngeal herniation, which is actually the reason why there is greater papilledema degree in right eye when the lesion is actually present in the left eye. Left side.
There's a midline shape. You know that drainage system is blocked. You can see that there's a midline shape.
Yes, sir.
That is one obvious reason of the slide.
Yes, sir.
Yeah, finger count. Yes. Can you go back to the front? What was the duration? If we have time, it is 6 or only there and we are having time. That is the reason I'm asking. Can you go one more slide back? One more. Yeah. And one more slide. Yeah, that is okay. If the color is not there and the hemorrhage are not that much. Okay. I don't know whether it is in the chronic papilledema. Still, we cannot say that this is the colloid body that after isolates are there. Forward one more slide. Forward. And over here, because finger count we have told in the left side also. Na? So this eye, subtle panel you can say, but over hyperemia does mild, so vision loss will not be there.
Sir, actually the patient, okay, how I say
Disoriented,
this?
you can say
Yes,
the
sir.
patient was disoriented, we were not able to
Yes, sir.
exactly gauge the vision.
But-
Because this is not you're collaborating or going in temporal relationship with your vision, this image.
So she had cataract also, like it was a very early degree of grade of cataract,
You
but
can get such a good fundus picture.
Photo.
That means the cataract was not so.
Okay.
During the entire period of the follow-up, the patient would not have been disoriented.
Yeah.
It would only at one time.
One time.
And I mean, at presentation probably, but maybe eventually all this workup would not have been done in a disoriented
it's very
state.
difficult.
A disoriented patient does not sit on an OCT machine and gets all this.
And that's the good quality of OCT
Yes.
with SNR 5 or 6.
Just a few suggestions for your presentation for future. Too many crowded slides.
Yeah.
You read entire theory as if it's like your seminar, it's a case presentation. So the crispness needs to be there. you have a poor vision like counting finger close to face, there's no mention of a PR after patient getting oriented, no measurement of pupil size. So these are the things relevant to a neuro-ophthalmic workup. It's not like a routine OPD presentation.
You have to highlight, as the madam is saying, you don't have to read all the slides.
Yeah, I mean,
Just highlight
the
whatever you
pictures
want to
should
do.
have been the highlight.
Yeah.
And I don't know, can you please go back? The right eye.
This
And
is
look
that-
at the
this is
fundus
for your
photo of the
learning.
right eye. Yeah, because this is a learning platform.
Definitely.
Where is the... You have all these things happening at what time point was this at presentation? This was all done on the day the patient presented to you?
No, ma'am, actually-
How many months or,
Ma'am,
days post the presentation or post the symptoms? That is what is relevant to give us a timeline as to, how things have been going bad for the patient. So, just for future, not to criticize, but
Yeah.
when you mention any grade, you must mention the grading system, so whether you use the modified Frieson's grading system or whatever you use. So that all needs to be mentioned for the presentation techniques. And the pictures should speak. You should not mark these things. You've just written them down for your ease to read them out. But you should be able to describe an image. And that's what should be the center of the slide.
So could I have saved that time? I'm not reading all of that slide. And the macula is not there on the OCT itself, whereas the upper image, some certain exudates are there going towards macula.
Yes.
Okay. So I don't know which OCT is used. So now that the OCT can capture from this one to the macula.
That's what happened. You made
This
it
is
right
not the
time,
right
this is the
eye.
left side.
Yeah.
That is what happened.
Exactly. Oh, yeah.
This image is in the left eye.
That's what I said earlier. This is left eye. Look at that.
And for vision, again.
And what about the pupil you have read down the one eye, it's like some sluggish grade 3 and 7 eye. There is
Yeah.
RAPD we usually do that.
Yeah.
But for pupil, I
There
don't
is
know
no
whether
grading now.
there is
There is no
grading.
grading for the reaction. You went for that RAPD grading or?
And RAPD, you have to tell which eye is RAPD, not mentioned.
Yeah. Okay.
Next one, next.
And
It's for your
another,
learning.
in the last slide, when you come to exenteration, if you find a meningioma, it's definitely not necessary that the eye will be exented. Exenteration is not taken lightly. It is just done as a last end procedure.
Mama, I've written the condition when it's near the globe and it's
No, still no.
Discussion should be relevant to your case, not a general discussion. We are not discussing generalized meningioma. It should be referenced, latest reference, and that too in relevance to your case.
So meningioma is a common tumor and meningothelial is a histological diagnosis. Okay.
Other speakers, please now, it's for 5 minutes.
Yeah.
Please stick to the time, you are going to lose your marks. That's it.
Definitely.
Next, we have Dr. Zeba.
I'll be presenting a case of a tale of a great mimic which is labeled as Tolasahan syndrome mimicking retrovalvular neuritis. 41-year-old man presented with the chief complaints of headache and diminution of vision in the left eye since 15 days. The sudden severe throbbing type of headache on left side of forehead and pain around eye since 15 days, which was relieved with medication for a short duration of time. No history of diurnal or posterior variation is seen. He also complains of diminution of far and near vision in left eye since 15 days, which is of sudden onset, progressive nature and associated with painful eye movements. And no history of associated symptoms is seen. No history of similar complaints in the past and no history of other systemic comorbidity. Patient is on tablet aceclofenac TID since 15 days as prescribed by the local doctor. No significant family history. Patient complains of disturbed sleep patterns due to headache. Vitals are stable. General and systemic examination is insignificant. On ophthalmic evaluation, the facial symmetry and ocular alignment is maintained. Meconial reflex test is central and extraocular movements are full and free in all the directions. On ocular examination, counting finger is half meter and relative apparent pupillary defect is seen in left eye. The right eye findings are insignificant. The fundus is within normal limits in both eyes. Optic nerve examination of optic nerve is done by the pupil color vision brightness and confrontation suggestive of left eye optic nerve dysfunction or the cranial nerves are intact. This is the summary of my case. Our provisional diagnosis was left eye retrobulbar optic neuritis based on the clinical examination. Other differential diagnosis it can be the optic neuropathy due to ischemia, trauma or toxic agents or due to the compressive lesion. All the routine investigations has been done and everything is within normal limits. The T1-weighted imaging with fat suppression on axial section is suggestive of ill-defined homogeneously enhancing soft tissue at the orbital apex and the superior orbital fissure. The report was suggestive of the likely inflammatory which was of Tolosa-Hunt syndrome or sarcoidosis, the differential diagnosis of infective etiology. Sarcoidosis and infective etiology has been ruled out based on the clinical examination and the laboratory investigations. There is no evidence of the involvement of the cavernous sinus in this MRI report. So, a clinico-radiological diagnosis is the Tolosa-Hunt syndrome mimicking left eye retrobulbar neuritis. But we have started treatment empirically based on the clinico-radiological diagnosis, and we have given injection IV methylprednisolone 1 gram in 200 ml NS for 5 days. Within 48 hours of the starting of the treatment, we can see the resolution of the symptoms. So, what's the final diagnosis? Let's see. We have asked the patient for follow-up once in a month. Since we are following the patient since a year, and each follow-up, ocular examination and systemic examination is being done. Patient is completely fine. No evidence of sign or symptom pointing to the probability of any other disease. So finally we came to the diagnosis of the Tolosa-Hunt syndrome being a diagnosis of exclusion. Tolosa-Hunt syndrome is a rare idiopathic disease with incidence of 1 case is seen in the median population per year. Painful ophthalmoplegia is the hallmark of the disease. The third cranial pulse in the cavernous sinus site is the most commonly seen. But here our patient has presented with the symptoms which was deviating from the normal presentation. I am concluding my presentation. Tolosa-Hunt syndrome is a diagnosis of exclusion. It is rarely seen with the optic nerve involvement alone. Neuro-ophthalmology is full of puzzles. We need to be meticulous in doing the clinical examination and ordering the lab investigations. Thank you.
It is a standard set of diagnostic criteria for Tolosa-Hunt syndrome.
Yes.
So, can you please mention that what was looked at when you labeled your patient? And did you have any follow-up?
Yes, ma'am. For 1 year we have followed the
Please. Did you have any follow-up images of the extraocular movements?
Yes, ma'am.
So,
It was full.
yeah, that needs to be documented when you present a case on a platform. We cannot take things at your word. Second, after the oral steroids were tapered, did the patient require any sort of immunosuppressive treatment?
Second thing you said that was already fine because around 2 days also okay. The image was not innocent with the section that is showing was only a MRI image. Okay. And you said that the other side was also there. Okay. So the reason I think was the vision involved, all the extraocular and the normal, but how come that your optic nerve is involved?
Orbital apex mainly, and there was involved towards the superior orbital
So
fissure.
that we are related.
Then you should have chosen that cut only to highlight it rather than generalize the entire picture of the
You
entire
got
scan.
the CT scan done? You got the CT scan?
CT scan is not done. It's only MRI or brain orbit contrast enhancement is.
We have made so much of a large arrow. I'm not able to see which you are going to point out. Why this large?
This is pre-starting IOCMT3.
Yes, ma'am.
Okay.
Any imaging done post-treatment? Because you're saying 1 year follow-up
Yes.
and no recurrence at all.
Yes, ma'am. Patient was not willing due to financial thing from outside to get it. So we didn't get it
And
done.
There is no documentation.
And if the apex is involved, the movements are completely free. It's little.
One more thing, this is not a contrast enhanced image because I'm not able to see the visual artery. also hard to show. We have to have a contrast and I think CT scan must have also been done. The patient was directly coming for the first time.
Yes. No, he was constantly outside the headache, sir.
Many times the patient comes to the institute, they are having a CT scan in the larger section of images different. And now be careful about this. I think आपने वहाँ से उसको क्रॉप करके यहाँ पे किया है. That is the reason the arrow is such large. Okay. You have to choose particular place. With this image, the lesion is going into the corona sinus. The people facing is on the corona sinus. You can see the IC both side. Okay. I think this is on the middle of the corona sinus. So this IC is larger than that. So it is in the middle of the corona sinus. This section. This is a node. I go by this image. And you have to double check the contrast on this image. This image is also not showing that there is a contrast. Okay, thank you. I think this is the learning for
Pregnancy-induced hypertension is defined as hypertension that develops as a direct result of the growth uterus. It includes gestational hypertension, preeclampsia, and eclampsia. Preeclampsia and eclampsia are important causes of maternal and fetal morbidity and mortality. It contributes 10 to 15% of maternal mortality. Ocular involvement occurs in majority cases of pregnancy-induced hypertension. Poorly managed cases of preeclampsia and eclampsia can result in irreversible blindness. So the aim of our study is to evaluate the ocular manifestation in women with pregnancy-induced hypertension and its direct association with the severity of the condition for better management. The study is a descriptive cross-sectional study done in a tertiary care center from July 2023 to 2024. 100 patients were included and all patients were examined with indirect ophthalmoscope using 20T lens. So, all diagnosed cases of preeclampsia and eclampsia admitted in the obstetrics ward with informed consent are included in this study. Patients with previous history of diabetes mellitus, hypertension, renal disease, and systemic disease, HIV, hematological disorders, ocular trauma, and other ocular disease prior to pregnancy are excluded from the study. And all patients unwilling to participate are excluded. In our study, we included 100 patients with pregnancy-induced hypertension. Among them, 91 patients were diagnosed with preeclampsia and 9 patients with eclampsia. A brief obstetric history followed by thorough ocular examination, including visual acuity, done using bedside unilluminated standard chart. Anterior segment examination was done using torchlight, and dilated fundoscopic examination was done for all patients. Highest systolic BP recorded was 190 mm of mercury and diastolic blood pressure 140 mm of mercury with mean systolic pressure 155 and mean diastolic pressure 97. Ocular symptoms were present in 20% of severe preeclampsia and 100% of eclampsia. All patients had visual acuity ranges from 612 to 660, depending on the severity. Most common impeding symptoms noted were headache, 50% of the study population, followed by blurring of vision, 24.7% of the study population. Fundus changes were seen in 47% of the study population. So this is the distribution according to the age group. Here you can see the lowest minimum age was 21 years old and maximum was 14 years old, and maximum patient belongs to 26 to 30 years age group. This is the column showing distribution of patients according to gestational age. Minimum gestation age was recorded was less than 28 weeks and maximum for 34 to 37 weeks. But maximum patients present were 28 to 34 weeks of gestational weeks. Here in the pie diagram you can see eclampsia 9% of the population, and preeclampsia according to severity, severe preeclampsia was in 41% of the total preeclampsia patient and moderate preeclampsia in 50% of the population. Anterior segment findings were found in 12 patients, 4 patients with conjunctival congestion, 3 patients with subconjunctival hemorrhage, 3 patients with chemosis, and 2 patients with lymphedema. According to fundus findings, arterial narrowing was in 17% of the population, arteriovenous closing 12% of the population, cotton spores was in 6% of the population, and retinal hemorrhages 9%, and papilledema in 3%. According to kit and regional classifications, we have divided the hypertensive retinopathy in grade 1, 2, and 3, grade 4 hypertensive retinopathy. Here the blue color showing in a pie diagram 36% for grade 1 and orange grade 2, and 25% showing in the grade color grade 3 and 6% with grade 4. So headache and blurred vision were the most common impending symptoms in our study. Out of 100 patients, only 12 patients had anterior segment findings, and they also had posterior segment findings. Fundus changes were seen in all 100% cases of eclampsia and 42% of the total preeclampsia patient. All patients with fundus changes had blood pressure greater than 160 and by 110 mm of mercury. So in the conclusions, we can say that ocular involvement with fundus changes is quite common in patients with preeclampsia and eclampsia. The ocular involvement is quite common, but is rarely being investigated. Observing retinal vasculature may provide clue to status of vessels in other parts of the body, including the central circulation, greatly assisting diagnosis and prompt treatment. So obstetricians should seek for routine fundal examination by ophthalmologist in all preeclampsia and eclampsia patients in view of fetal and maternal well-being. These are my references. Thank you.
Whatever you are preparing the results now, it's all methodology. The first part of the first slide and the results, it's all methodology. You have to see that 100 patients were included, divided into two, like that. Then after the next slide only the results are.
We have not shown any fundus photograph of your patient.
Actually, we have not done OCT. We don't have
Not only
what.
OCT, the fundus photograph of your patients. They should be there. These are the 100 patients you have mentioned that you have seen 100 patients. Okay, 100 patients.
Yes.
They are not showing a single photograph of your patient. Do you have fundus camera with you, sir? You have fundus camera?
We don't have fundus.
Camera.
No.
Okay, you must have mentioned it. These are all the findings objective to them. All the subjective to them.
You can take one with your mobile and then for that sake of presenting.
You have done indirect. All these patients will continue. At least you can have that patient. For a good presentation, the photograph of the patient should be there.
No.
And we are reading now, just as the madam said, we are reading now more of the slide again. Because you are on ocular manifestations of hypertension.
Yes.
You were reading about the blood pressure, systolic, diastolic, diastolic, mean. That is not needed to read about that, because we are not concerned because your title is ocular manifestation. So, because you know what is eclampsia, what is preeclampsia. What is the difference between the hypertensive changes in your preeclampsia, eclampsia, and your malignant hypertensive retinopathy? Difference between these?
In preeclampsia and eclampsia.
So that the findings you are having in your gestational, I should say, or the pregnancy hypertension, and a normal patient who are not having any pregnancy or a male patient having hypertensive retinopathy, crisis or hypertensive retinopathy. Is there any difference between
Yes, sir.
findings?
Yes, sir. In preeclampsia or eclampsia, there will be narrowing of the blood vessels, and it is actually pregnancy-induced hypertension. So it occurs after 20 weeks of gestational age, and it can persist to 12 weeks after delivery. But in case of chronic hypertension, the patient will get reached before 20 weeks of gestation, and it may persist longer. Fundus changes in
A normal patient, any patient, a male or a female, one pregnancy is hypertension and one is hypertensive patient, normal hypertension. Is there any difference? First thing. And you have mentioned the grading of hypertensive hypertension. Which grading you were using?
Kid and Wisner
You should have mentioned according to this classification. These are the. Do you know anything about press? What is press? PRES? PRES, you know? 100 patient is a good number. They have not mentioned anything about the press. It's a good number.
Very basic statistical qualitative analysis to look at into the profile of your patients. You had such a good success. A lot of other parameters would have been there, and it's just
Maybe it depends on the gestation age.
Your
In this case, no, ma'am.
was it a pregnancy or a water and what about your, have you followed them postnatal also?
Yes, sir.
What
But
about the
the,
changes then? You have mentioned, that would be a good thing. What happened to those patients which are having this large? Yeah, I know your study also.
The lower value.
Yeah, that would be the a message to the mass or a message to the community of ophthalmic or the gynae community or obstetric community. Okay, this can be there. Don't worry about this. Okay, control your blood pressure. And you should come to us also. Right?
There are no financial support and sponsorships or any conflicts of interest in my presentation. So my case report was of a 29-year-old gentleman who's an IT professional living in a densely populated locality in North India, presenting with chief complaints of ongoing fever for 7 to 10 days, which was undocumented. It was sudden in onset, painless diminution of vision in right eye for 3 days, with a central black spot in front of the right eye for 3 days. Coming to the history of presenting illness, the patient was apparently well a few weeks back when he complained of low-grade fever, which was insidious in onset, undocumented, and reduced on treatment with paracetamol. It was not associated with any evening rise of temperature or chills and rancor. He developed diminution of vision 3 days ago, which was associated with central black spot in front of the right eye, which was single stationary and non-progressive. There was no history of any trauma, distorted images, tinnitus or hearing loss, previous ocular surgery, eye pain, flashes of light, exposure to any pet or stray animals, any history of systemic illness or previous surgery, and no significant family history. Coming to his past history, he was being constantly followed up with a dermatologist for having 2 patches of hyperpigmentation beneath his right side of the face. He was diagnosed of segmental vitiligo and started taking treatment from a local practitioner. Previous documents suggest he was on long-term topical steroid cream for the same lesions. Lesions were static and non-expansive, non-pruritic, with no history of any reduced sensation of the patches. This was the clinical presentation, and these were the vitiligo patches. Coming to his personal history, he was having no addictions and his sleep and bowel habits were normal. Family history, there was no history that was significant, no history of type 2 diabetes, epilepsy, or hypertension. On the general examination or presentation, the patient was only febrile with a temperature of 100 Fahrenheit. CNS examination had a GCS of E4, B5, M6, and the rest of the systemic examination was within normal limits with no lymphadenopathy noted. Coming to the ocular examination, his unaided visual acuity in the right eye was 20 by 400, whereas in the left eye it was normal, which was 20 by 20. His color vision on the Ishihara chart was defective. Contrast sensitivity on the periopsin was log 0.2, whereas in the left eye it was normal. The eyelid and dexa had poliosis of the lower lid lashes, as well as the hypopigmented vitiligo patch. Coming to his cornea, which was normal, pupil showed a relative afferent pupillary defect on neutral density filter of grade 2, and anterior chamber findings had plus 0.5 cells without any flare. Coming to his fundus examination on distal direct ophthalmoscopy, both eye fundal lobe was present. Slit lamp biomicroscopy showed the right eye to have disc elevation with obscure disc margins and hyperemia, with diffuse macular edema and striae. On indirect ophthalmoscopy, there were dilated and tortuous vessels, foveal reflex was absent, foveal contour was blunted with striae, macular edema was present, the periphery was within normal limits. OCT macula suggestive of neurosensory detachment with cystoid macular edema. So these were his fundus photo images with striae present on the macular area with disc edema, which was on modified recent grade 3. Whereas the left eye was normal. Coming to his OCT pictures, there was intraretinal cystoid spaces with neurosensory detachment and fluid and loss of foveal contour. Whereas in the left eye it was normal. Coming to his OCT RNFL findings, there was significant disc edema with an average RNFL thickness of 211 and obscuring of the cup, whereas the left eye was normal. Coming to the differential diagnosis for my case, I made the diagnosis of right eye neuroretinitis with vitiligo due to either ocular tuberculosis, which is considered one of the most prevalent things, QTE in India, sarcoidosis, syphilis, Gardnerella hemsley, as our textbook says, is one of the most common features, but American data and Indian data do not corroborate. Then because of the vitiligo patch, I was constantly confused with Bob Harada syndrome. So I went for further examination with investigation and did an antibody for Bartonella, which came out to be positive with IgG values of 1:320, the normal values of which was 1:128. MON2 was also positive, as is in most of our population, with ESR levels that were raised. So my working diagnosis on the level of our serum IgG antibody levels came out to be right eye neuroretinitis due to Bartonella species, and we started a patient with oral doxycycline 100 mg twice a day for 2 weeks. Now on follow-up, the patient came back with improved vision of 20/20, and on the second week he came with an improved vision of 20/32. With continued treatment and color vision also improved, right eye pupillary reaction came out to be normal without any visual field effects. We only had a few exudates that were left behind with the normal OCT findings, and exudates would obviously take more than 3 to 6 months to resolve. But the vision was improved and the patient was happy, and these were the visual field. Follow-up was done with oral doxycycline, and it was continued for the next 4 weeks. Total treatment duration was 6 weeks. Oral doxycycline was given, and patient is currently asymptomatic and is being continually followed up. Thank you so much.
MON2 was 30 ml. What have you done? So 30 ml patient population.
Right, sir.
And duration was hard.
Yes, sir. It was hard, but then I did not go for a quantiferon gold test because the patient was asymptomatic. So the respiratory medicine people were a little skeptical on starting ATD because combined toxicity and other side effects were. So we weighed the risks and gave a trial of doxycycline.
Anything apart from quantiferon gold, any other test you know that you were
So this, we can do a PCR for
apart from IGRA,
IGRA.
apart from IGRA, there is no
Did you test anything else except for Bartonella?
Ma'am, not serology-wise because the patient had his own financial constraints. So this itself was a test that costed 10,000 to the patient. So after that, he was a little hesitant to go for other testing, but we would have ideally wanted to get him tested for a viral PCR panel and to rule out diffuse unilateral subacute necrosis and toxoplasma toxocariasis. Maybe to go for an HRCT to rule out sarcoidosis. But again, they were less commoner, and we stuck to our 2 differentials of tuberculosis and Bartonella.
considering the material patch.
That's right, sir.
Suspicion of having leakage also.
Yes, sir, but again, his integumentary changes were, since they are a late onset that happened, and it was not corroborating to his history, which was very acute in onset. So I didn't consider leakage on top as a vitiligo.
Pigmentation improved or that
The vitiligo patch was there, sir. It did not improve.
it was not in conversance with you?
Yes, sir, with my diagnosis. Yes, sir.
Leaves the presentation.
Thank you. Thank you.
Yes.
Today I am presenting my topic on turning the tide, idiopathic intracranial hypertension and anemia next stage. As we all know, ILH is a neurological disorder characterized by elevated intracranial pressure without any detectable mass and structure. So overall incidence is 1 to 2 per lakh in a general population with female predominance, age is to 1 ratio. Aim of my study is to find a demographic insight, to find the potential correlation and to explore the physiological mechanisms linking the IH and anemia. So we used the electronic medical record and we searched in a month of January to April. Keyword uses papilledema and we found 137 patients was diagnosed with the papilledema, and we included patients above the age 16 years with a symptom as per the 2013 revised IH 45 Dennis criteria with clinically diagnosed and confirmed through the neuro imaging. And we excluded patients who were less than 16 years of age with other causes of bilateral disc edema and secondary increased IC. We use a multifacet approach and we diagnosed that out of 137 papilledema, there were 63 patients were diagnosed with IAH, and among that 36% were anemic. Moving to the result, and we found that all our patients were female with the mean age range headache, 63 out of 63 patient, with presenting best corrected visual acuity 6/6 and normal color vision. And we found that 4 out of 63 patient has a 6-nerve palsy. Investigation were done and we found that in HFA enlarged bad spot was there in 23 out of 63 patient, with RMFL thinking the OCT present is more than 50% of the patient. Neuroimaging was done and we found that partial MD sign was present in 61 out of 63 patient, and elevated opening patient number puncture were present in 60 out of 63 patient. We did further blood investigation, and as per the WHO organization anemic grading, we found that most of the patient in our study lies in a moderate anemia, that is 11 out of 23 patients, followed by the 9 out of 23 patients were in mild anemia, and then 3 out of 23 patients were in severe anemic. We also found that unfortunately we were not able to find the cause of the 11 out of 23 patients why they were anemic. So in this study we also found that anemic prevalence do not vary significantly with age among IH patients, suggesting that age is not a determining factor for anemia at IH diagnosed patient. We found in our study that most of the patients were lying in a grade 1 papillary edema, that was 26 out of 63 patients, and there is a potential relationship between the grade of anemia and severity of anemia was present. We found that 7 out of 63 patients were thyroid, forming the 11.11%. So there is a thyroid disorder can influence the risk of both IH and anemia. But in our study, we were not able to find any significant link between the IH and obesity. As we know that in foreign Western world, the main risk factor is obesity. But due to the prevalence of anemia more in India, we determined that IH is mainly because of the anemia, not because of the obesity. Limitation, whether because this is a retrospective study and only small sample sizes used in 63 patients were included, no full hematological workup was done and inconsistent follow-up. Since we know that anemia is a condition in which the blood lacks enough healthy RBCs and hemoglobin to carry adequate oxygen to the body tissue, and IH is a chronic disease, due to which it causes inflammation, disruption of the normal red cell production. So several hypotheses was there which were proposed in the literature. Firstly, because of the decrease in the oxygen carrying capacity of the hemoglobin causing the local hypoxia, which causes more capillary permeability and brain edema. Secondly, because of the altered blood viscosity, as we know that most of the patients having the iron deficiency anemia, this considered cause the hypercoagulative state and increase in viscosity. And thirdly, because of the decreased hemoglobin will increase the cerebral circulating volume. These all factors increase the intracranial pressure. There was also overlapping symptoms between the IH and anemia, since headache, visual disturbance, dizziness, tinnitus is also present in anemic patient because of the decrease in oxygen delivery in hypoxic condition. As a conclusion, while there is a correlation between IH and anemia suggested, the relation is complex and requires further investigation. We enhance the overall treatment outcome and improve the quality of life patient-centered approach to care. Why this study? This study we have chosen because there is a potential overlapping symptom, and correlation between the IH and anemia is still an ongoing research. And thorough evaluation of hematological status of diagnostic workup for IH is needed, and there is a collaboration between the neurologist, hematologist, and primary health provider should be there. At the end, I will just say that a holistic multidisciplinary approach is vital in managing the patient with IH and anemia. These are my references. Thank you.
What's the retrospective study?
Sir?
What was the retrospective?
Yeah, we have done January to April.
Significant number of patients were anemic.
What is the patient with you?
Significant number of patients were anemic.
Yes, sir.
Have you followed them up? You are having the phone number. What happened to those patients regarding the IH? Because you are talking about IH and anemia. Definitely the patient there were not now visiting you.
Yeah.
You must be having the phone numbers. If you were sent to the study, we followed up on the phone. Patient was called back. The status of the person was seen. Okay. Case of patient was an initial patient.
Yes, sir.
On the criteria were followed.
Yeah, everything was followed. Only 11 patient out of 23 we were not able to know like, why they were. Other patient we have like during the history taking we have asked like what was
So
the
that would be a very good point.
Yeah,
You
yes.
can add on to your study,
Yeah, I need
and
more.
that will add a lot of value to your work which you've already done.
Yes, sir.
Because if they are diagnosed with IH, they must be on long-term follow.
Yes, sir.
Partial empties can be incidental finding. Okay.
Nice.
So IH definitely not associated with when the partial empties are there and you say that now IH is there. Until unless they have not done the CSF operation.
Say sir, 40 patients.
Was that?
Yes, sir, for every
You
patient.
are there, that means the patient was seen in the neurology.
Yeah, yes, we have referred the patient and whoever was anemic also we have referred to hematologist. But we are not able to follow the
You are
what
not
was the
able
result.
to find the cause of anemia also.
Yeah, 11 patients.
They have correlated this anemia and the iron. So only one variable was there. There are a lot of multi-factorial may not be due to anemia. So
Definitely. So anemia can be vitamin B12 deficiency.
Yeah, that we didn't do like what type of anemia was
one
there.
variable you have.
We used only hemoglobin level. Other hematological things we have not done.
This was a retrospective study.
Yeah, yes.
So you not done anything prospective.
No, not.
Yeah, if you have done it recently, you have correlated recently, you can better go back and call the patient and now you see whether this scheme has resolved, whether they are on diamox right now, or how many days they were put for diamox, and the anemia was corrected, for how many days they were put on diamox. If after correction of anemia, the diamox was withdrawn, but the anemia was resolved, that means this can add to, okay, it was one of the reasons. Because now the patient is not on diamox. Okay? So you have to give a long-term diamox of fuselmide or other drug.
The anemia also treated along with the anemia.
Yeah, yes. Like we have referred the patient because his symptoms are overlapping now. So we don't expect Yeah, yes, yes, we have.
So did you do a literature search where you found out which methodological parameter correlates the best with the action?
Yes, we are.
Not just, I'm not saying individual. Which among the entire, iron assessment panel, the entire workup. There are many other parameters, right? Which of them correlates best with that? There are several studies. In Indian literature. It's not just one. Anyway.
Anybody come and we can take a photograph?
Ophthalmology, which happened due to neurocystic cirrhosis. So a 31-year-old young man presented to us with acute onset of painless vertical diplopia of 1 month duration. Complete ophthalmic evaluation was done, B scan, MRI, PPCT, IOP, everything was done. So he actually had a sudden onset of headache 15 days back along with a fever, sudden loss of consciousness, with seizures, hospitalized for the same at the local hospital. It was a multi-speciality hospital. He was treated there with medications alone. He noticed double vision after regaining consciousness, and then after 15 days he presented to us. He is a vegetarian by diet. So what actually went wrong? This is a young man presenting with seizures and loss of consciousness. He had diplopia. He was actually seen by an in-house ophthalmologist, but he was reported as no diplopia elicited during examination. Further evaluation or imaging was not airtight. So this is a man, he had 20/20 excision in both eyes, elevation of 20 degree, right exotropy of 18 degree with left hypotropy of 14 degree, rest of the anterior segment, pupil and fundus, IOP, everything was normal. This is his 9 days picture. The extroversion was completely normal, but on lower version there was erection deficit along with an tacit nystagmus on adduction. Our case was also mildly limited. So we went ahead and did a B scan. We could see there are cystic lesions which are present along the superior rectus and the medial rectus muscle. This is his brain MRI, which revealed multiple cysts along the brain parenchyma, along the mid-brain dynamic region. So we came to a provisional diagnosis of right immunonuclear ophthalmoplegia with Arcase palsy due to dorsal membrane syndrome associated with neurocystic sarcosis, along with an orbital cystic sarcosis affecting the SR and MR muscle. So we suddenly referred him back to a neurologist. Patient was started on the following medication, which include albendazole, prednisolone, atorvastatin, and ectoin. So he reviewed with us after 6 months. His diplopia has decreased as per the patient, orthotropic in primary gaze. Repeated P scan, but still showed some persisting cyst of smaller size in the middle rectal and superior rectal region. Ocular examination still showed a 10 PD exotropia with 12 PD hypotropia. So he was continued on steroid albendazole after consulting with the neurologist again. Post-treatment, this is the final MRI pictures. All the cysts around the mid-brain, parenchyma, everything has completely disappeared. So cystic sarcosis, as we all know, is caused by timiosodium. It is a unique lesion with poor sanitation. It can happen via ingestion of undercooked pork, contaminated vegetables, and food. Human cystic sarcosis commonly affects CNS. It can affect eye also.
In the eye, usually common sites are vitreous, subretinal, subconjunctival sites. Neurocysticercosis has long been recognized as a cause of dorsal midline syndrome. It can cause cerebrovascular complications and INR also. So, diagnosis mainly based on imaging techniques, CT or MRI. Medical therapy include antihelminthics, anti-inflammatory drugs. Orbital cysticercosis can be treated conservatively with a 4-week regime, but it should be followed by a tapering dose of 1 month period. Albendazole is usually well tolerated. Surgical removal may be required in some cases of subconjunctival and eyelid cyst. So, in conclusion, as you all know, neuro-ophthalmology can have a variety of presentation. A high index of suspicion is very much needed because it's always a puzzle. Cysticercosis can also have a variety of presentation depending upon the site of lodgement, mimic various neurological disorders. And in these cases, a high index of suspicion and appropriate imaging is very much needed to reach an early diagnosis. In all cases of orbital cysticercosis, a concurrent neurocysticercosis should be suspected and ruled out.
Go back to the slide which I have shown that is amazing. They are not clean and honest.